Thank you, Steve. And just delete the word very talented before blues guitarist. Thanks, everybody, for being here. The snow doesn't bother me. It makes me feel great walking around the streets and making all the great contacts I've made here at the university. It's also a great privilege to be able to talk about Obamacare, perhaps the most significant piece of legislation that's occurred in the United States in the last generation, to talk about the issues that it raises and the kind of dilemmas that it will create for the United States. I've titled my talk, or subtitled it, The End of the Beginning or the Beginning of the End, because the way things look now, the United States could go in two different ways based upon some of the tensions that have come across because of the legislation. I say the end of the beginning, and that's one way to look at the recent progress, which would suggest that the ACA, the Affordable Care Act, which is the official name of Obamacare, will create through various mechanisms and programs and initiatives a sustainable system in the United States which takes care of a lot more people than it used to, will maintain quality and do so at acceptable levels of cost. On the other hand, it could also be the beginning of the end, where we will see that the conditions and the responsibilities accepted under the ACA will lead to systems change that will be much more fundamental as things continue and as costs become realized. Now, this is a picture of me getting some intravenous antibiotics a couple of years ago, and I like to show it because one thing, as a professor who teaches health administration courses and looks at a lot of statistics in my research, it's easy to forget that healthcare is a very personal thing in which we all become involved at some point, at one point or the other, and either for ourselves or for people for whom we're responsible. I'd like to say a few words about what the healthcare system in the United States looked like before the Affordable Care Act, so that we can have some perspective on what's happened since that time. Now, going back to 2010, the year in which the measure was enacted, you will see that the predominant way that people received health insurance in the United States was through private plans, and again, predominantly through employer-based plans. The numbers here don't add up to 100% because people tend to be insured by a number of different types of plans, and so you'll get a figure a lot higher than 100. Medicare and Medicaid, our two major public plans, account for something like 30 or 31%, and at that time we had uninsured people comprising about 16% of the U.S. population. Now, in terms of what these plans would cost people, I've illustrated the plan that was offered by my employer in that year, very, very good selection of plans. And the plan that I have costs $339 per month. It covers me, my wife, and my 2 children. That's about 1/3 of the total cost of the plan. My employer pays the other 2/3. This, I would say, is fairly representative in terms of the choices that people have and the kind of out-of-pocket monthly costs people pay in the United States. Now, I mentioned that there were 16% or so of the population that was uninsured. And it's important to realize who those uninsured people tended to be, because that has important consequences for the policy dilemmas that we face today. Well, of course, the poor, that's understandable. Let's look at some of the other ones. Difficult to insure. That is people who are either out of the labor force or looking for individual coverage, which tends to be difficult. Sick and disabled, people with pre-existing conditions, understandably, were not attractive as clients to insurance companies. People who don't expect to use much, and that would account for a lot of young people, because when you're young, you're fortunate in not having the kind of healthcare risks you have when you're older. And then, of course, we have gamblers, people who are not afraid of taking risks, and free riders who believe that if they get sick, someone else will pay. Turning to the Affordable Care Act, this is a photograph of the legislation, and it's 2,700 pages long. I wonder whether any human being has ever read the entire thing, and I would doubt that anybody has read the entire measure and is conversant with all its various features. Now, one thing it's important to realize is that Obamacare does not represent comprehensive health care reform in the United States. It expands and protects access by giving a lot more people financial coverage for their health care, but does not change the financing and delivery of the system in the United States in any fundamental way. Most of the delivery system remains exactly as it was before the measure, and most people's health care is financed through Medicare, Medicaid, or private insurance exactly the way it was beforehand. Now, it's not conclusive reform, just to expand on a few things I said a moment ago, because a lot of people still lack insurance and will lack insurance as late as 2019. The system remains non-comprehensive and very expensive. I think that we pay about 17% of our GDP for health services, and I believe it's about 11 or 12% here in Canada. The law mandates no system-wide controls on medical costs. So one thing I like to say is, although the press and many people like to refer to Obamacare as an overhaul of the system, it isn't really an overhaul of the system at all. Nothing gets repaired, nothing gets replaced. What happens is a lot more gas is put in the tank. A lot more resources are placed into a system which itself does not change. Now, some of the key provisions, for one thing, the two major ones, I would say, are the top two. That is, the eligibility for our Medicaid program is expanded. So Medicaid is a program in the United States that covers poor people, and the floor under which you can apply for Medicaid is raised, so people with higher incomes than they had in the past are capable of applying and receiving Medicaid benefits. Also, in the past, it was very difficult to get financing under Medicaid if you didn't have children. And for whatever reason, a single adult was often not eligible for coverage. But today, a single adult can receive coverage under Medicaid, and that will result in a significant expansion of the number of beneficiaries. Another important point is that groups of uninsured people are put into subsidized purchasing pools. And that is sometimes called the exchanges. I was just reading one called Covered California, which enables individuals who don't have insurance and don't have an employer who might provide that insurance to basically get on the web and select a plan, sign up for it. Anybody can do that. There is a system of subsidies. And so if you're low income, the plan will cost you less than it would if you had a high income. And subsidies are quite generous, in my opinion. You can get a subsidy up to $88,000 of annual income. So that is 4 times the federal poverty level. So up to $88,000 as a family, you can get some help from the government when you sign up on an exchange. The plan also mandates coverage by individuals and large organizations. So one very important feature of this is that we have what is called an individual mandate. That is, everybody in the United States has to have insurance. If you don't have insurance, you have to pay a fine. Now, that fine is interpreted by our Supreme Court as a tax. It's legal for the government to impose a tax, but not to exercise a fine. And again, it was one of the great items of passage in the history of the legislation. But in any case, the individual mandate is a major part of the picture. Business firms are also required to provide insurance. If you have more than 50 people, you are required to offer insurance to your employers. And you have to offer insurance to 95% of your full-time employees. Again, if you go into the detail in any of these points, you'll find that there is indeed a great deal of detail. It improves pharmaceutical coverage for elders. There's some interesting and potentially important reforms imposed on the insurance industry. One is that insurers must offer insurance for people's children up to the age 26 if they're living at home. There is an exclusion there is a prohibition of excluding those people who are difficult to insure with pre-existing conditions. The plans are prohibited from capping benefits. In other words, plans used to say your benefits will be capped at $1 million worth of coverage. $1 million can go very fast if you have a serious chronic illness. And it sets a minimum of a medical loss ratio. That means that the insurance companies can only spend a certain amount of their funds on purposes other than paying for actual health care. Now, what is the impact? It's expected that there'll be 30 or 33 million people who are newly insured when the plan reaches maturity. Still, there'll be 26 to 27 million people who are uninsured, and those individuals are folks who are not citizens. They might not be covered by Medicaid because every state will not provide the same benefits and the same opportunities. Native Americans, undocumented immigrants, etc. And people who choose to pay the fine, I guess we should call it a tax, people who choose to pay the tax rather than get insurance. Now, this slide I've entitled Deficit Control Provisions, which was the most neutral way I could organize these data, because the question on everybody's mind is how much is this all going to cost? And basically, if it costs more than the mechanisms that are being put in place to finance it, it will increase our national deficit, which is already very high. So another way to look at this is where is the money coming from and how much is it going, how adequate will it be? Well, in terms of deficit control provisions, we have something called an Independent Payment Advisory Board, which is appointed by the president to monitor cost of the system. And if those costs, at least for the Medicare piece, increase faster than they're projected to increase, the board can recommend action, and the action can be rejected by Congress for what that may be worth. Okay, reduction of payments to hospitals and health plans. A big piece of the financing of this measure comes from reduction in payments to hospitals under Medicare. Hospitals are a huge consumer of healthcare dollars, and as part of the numerous agreements that it took to get this through Congress, there will be major reductions in some payments to hospitals. And I should say the hospitals will recoup those losses because with a lot more patients and payment for patients who used to be written off as bad debt, they will recoup these figures. But in any case, that is one of the major mechanisms. Reduction of some Medicare programs. One is known as Medicare Advantage. It's an Advantage program which is going to lose support under this measure. Private sources of support for the program is, first of all, there are new taxes on private plans and high-income earners. This you have to read the legislation pretty carefully to find. And it also seems to be coming in tiny little bits and pieces that people realize 2 years after the legislation made it through. So, for example, my employer has to pay a tax on the insurance that it provides for we faculty and staff. So this is, again, there is a tax on plans that are offered by employers already, and something people didn't know about, but you find out about as time goes by. High income earners, how high an income? I think you have to have $250,000 in income, which doesn't quite put you in the 1%. I think it puts you in the 10% or so. There's a higher tax for special surtax for Medicare, in addition to which the ceiling above which incomes are taxable for Medicare have been increased. So a lot more money will be collected through taxes, although that's something people are just beginning to realize. There are industry fees. Industry fees have been levered on the pharmaceutical and hospital industries, and something called the Cadillac tax. As that sometime in the period under which the legislation is unrolling, and I'll illustrate that in a minute, a so-called Cadillac tax is supposed to be imposed. I believe that Cadillac tax, so-called Cadillac tax, will impose a tax on health insurance whose value is above a certain level. I think it's $12,000. So if you believe that $12,000 plan represents a Cadillac, then the label Cadillac tax is merited. Other taxes, if again, there'll be a certain amount of money that will be collected from people who do not choose to offer insurance. And again, for firms over 50 people with over 50 employees, if they don't offer insurance, they'll also have to pay a tax. Now, there are some other initiatives within all those 2,700 pages which have implications for cost control. One of them is accountable care systems. They're a sort of a managed care system which attempts and is believed to be able to control the cost, and these entities will receive a premium from the government if they in fact do control costs. I won't go into all these different things except to say that there's also a lot of comparative effectiveness research, which is again funded by the government, which is intended to identify treatments which are effective versus treatments that are ineffective, and there will be a mechanism for encouraging reduction or elimination of the ineffective procedures, therefore saving money. Challenges of implementation. Here's another photograph. This poor soul is undergoing a lot of trial and tribulation and some probably unnecessary medical test, and I figured that's a good way to talk about challenges. For one thing, let's review the stages of implementation. The exchanges have been implemented. I was just looking at the one from California this morning. Basically, people are required to sign up if they don't have a coverage under Medicaid or they don't have a private insurance plan or coverage under Medicare. They're required to go to one of the exchanges and sign up for a plan. If you don't do that by the end of March, you're going to have to pay the tax for 2014. So there's a big push right now to get people signed up. The private insurance plans, that modifications and reforms I was just talking about, will be phased in this year. The individual mandate, the tax associated with the individual mandate, will increase to a maximum in 2016. The Cadillac tax I was talking about a moment ago will be implemented in 2018, and in 2020 the states will pay part of Medicaid expansion. Now, let me say a few words about that. Medicaid is jointly funded by the state, by the individual states in the U.S. and the federal government. So the richer the state, the higher percentage you pay. So California is a rich state, so we pay something like 50%. Now, since the federal legislation mandated that states expand eligibility for Medicaid as one of the mechanisms for getting people into the insurance system, states would incur a tremendous amount of liability for the purpose of implementing that piece of the legislation. States didn't want to do that, so in order to gain passage of the measure, the law contains a provision that the federal government will pay for all the additional costs incurred by states due to Medicaid expansion. Now, I have to say, Medicaid is a very big deal for states. California pays about a third of its state revenues for Medicaid, and some states in the Southeast pay at least half, maybe a little bit more. I believe that Alberta and British Columbia do pay about 50% of your provincial income for health care. In the United States, it's a similar picture, although the coverage only extends to poor people in the individual states. So when 2020 comes along, that's going to be a great big year for liability for individual states, and it's going to be interesting to see how the states react at that point. Now, how much does this all cost individual people? Well, if you bought a plan on one of the exchanges, these are some representative figures as of last September 2013. Now, these are the lowest cost plans. You can select one of 4 plans. There's a so-called bronze, silver, gold, and platinum plan, and the more precious the metal, the more the plan costs, and the greater percentage of the costs the individual will incur will be paid by the plan. This one is for a silver. So let's take a silver plan, the medium range plan. Actually, this is the bronze. It's the lowest cost plan. Monthly premiums for a 24-year-old individual who's single. Single coverage. This is monthly, and curiously, there's quite a difference in localities. So for some reason, now the reason why the differences in income are there is that if you have below $25,000 for a single individual, you will get a subsidy. If you have an income that's above $45,000, you will definitely not get a subsidy as a single individual. So let's take a look at the people who don't get a subsidy. You can pay up to $205,000 if you live in Columbus, Ohio, and you're only going to pay $125,000 if you live in Chicago. And again, I don't know the ins and outs of why these plans differ in cost, except that I was reviewing some other figures this morning. It turns out there's some places where the cost can be at least twice this level. For some smaller, peculiar localities in the United States. Now, penalties for non-enrollment. The minimum is $95. I'm not sure what the income floor is for that one. But a single individual with a gross adjusted income of $30,000 will pay $199. For people married with 2 children who have $150,000 gross adjusted income, they'll pay about $1,300. So these are the fines you pay for not enrolling. Now, if you've done some mental arithmetic, you can see there's an issue here, but let's bring that one up later on. Now, in terms of challenges of implementation, one of the major issues that came up, one of the huge flaps that came up last fall when the exchanges became operational, is that people did find that their insurance was going to cost them more money. This was a big issue because President Obama had made a point again and again that if you like your insurance, you now have, you can keep it. And that was very convincing and reassuring to a lot of people. But it turns out that wasn't always the case. And here are some examples. In Nashville, Tennessee, a 27-year-old non-smoker before the ACA could pay as little as $41 a month for a bare bones policy, but now would pay $114 a month for the lowest cost bronze option. Now, why is that? That's because one of the insurance reforms that was part of the ACA increased the package, increased the range of services that needed to be covered by by private insurance policies following enactment of the law. So you could buy a policy very cheaply as a catastrophic care, for example, but under the ACA, you are not able to do that because the insurance companies are required to offer more services and therefore need to raise premiums. So you couldn't buy the same old stripped down policy. You had to buy a richer policy. And so here's another example. In Cheyenne, Wyoming, the lowest cost option after the ACA would be $271 a month, up from $82 prior to the ACA. And so this made people very unhappy because they tried to renew their policies and their insurance company said, we cannot renew your policy, or we will renew your policy, but it's going to cost you more. And that probably covers only about 1% of the population, individually covered people who have had the cheapest policies they could get. But still, it was enough people so that it was quite an issue for us. What have been the favorable developments since the passage of the legislation? Well, one of them is that the Supreme Court upheld the law. They upheld most of the law. The part of the law they did not uphold was that individual states cannot be required to set up exchanges or offer expanded Medicaid. And that's a big issue because a number of states have not chosen to do that. Obama got reelected, and that's viewed as an endorsement of the legislation. And as of a couple of days ago, 5 million people had enrolled in state exchange plans. Unfavorable developments since passage of the legislation. There were big technical problems with the websites when the exchanges were rolled out last fall, and again, that made all the papers, and opponents of the legislation had a lot to say about that. Some pre-existing policies were unavailable or more expensive. That just goes over the previous slide. Several provisions were postponed. Now, this is interesting. Over the last year, just the ones that I can think of offhand, and there are probably many more, is that the individual mandate, while not being postponed, the deadline was extended in 2013 through the end of this month. There is a 2-year extension on the mandate for employers to provide insurance for their employees. There are some peculiar bits and pieces, again, probably scattered all through the legislation, such as a requirement that an employer could not offer an advantage program to highly paid employees. You have to basically make all plans available to all employees. That's been postponed because regulations need to be written mandating the specifics. Enrollment is below hoped-for levels. There have been 5 million enrolled, again, as the deadline approaches and people realize they'll have to pay a tax if they don't enroll, and or to make use of the availability of insurance they didn't have access to before, there's a rush to enrollment, hopefully over the next 2 weeks. And however, the goal, the target was 7 million. We're closer to 5 million at this moment. Opposition in Congress. The Republicans have lost no opportunity. There are probably more than 100 different measures that were introduced into Congress over the last year or so to either repeal, defund, or otherwise debilitate the legislation. It gets through the House of Representatives, our lower house, which has a Republican majority, but doesn't make it through the Senate, which at the moment has a Democrat majority. So you could call that a lot of harassing maneuvers. In terms of other things going on, state-level opposition, remember in the United States, the insurance companies are chartered in the individual states, and although the federal government can issue mandates for them to follow the actual administrative and regulatory machinery for the insurance industry is state by state. So in the so-called red states, Texas, Arizona, others that have Republican administrations, there has been relatively slow movement. In order to have an insurance industry that complies with the mandates, there has to be regulation on the state level, and those regulations either haven't been forthcoming in the red states or have been moving very slowly. Also remember that the states are not required, according to the Supreme Court, to establish exchanges or to set up expanded Medicaid eligibility, and the red states have not done so. So those are big issues because the federal government is limited in its power, and people who live in those states simply do not have the opportunities for insurance that people have elsewhere. Now, let's talk about public perceptions, again, as a potential challenge to the legislation and its future. Let's have a look at the total. These figures are from 2011. In terms of favorable opinions, large percentage like the idea of insurance exchanges, individual subsidies, Medicaid expansions, employer mandates, but only 33% are endorsing the individual mandate. It's a very, very unpopular piece of the picture. Now, if you look at Republicans, who probably at least 40% of the electorate, you get down to 18% favoring the individual mandate. So there are things that are basically popular. People like the exchanges, they like the individual subsidies, but when you get down to some of these other items, you see a great deal of public suspicion or opposition. Here's an update. Here's some figures as late as last year, just in terms of general favorability towards the Affordable Care Act. Again, it declines from 41% in favorable in 2011 to 37% in 2013, and that's a distinct minority of American voters. Future. Now, here I have a picture of the space shuttle, and the reason why I use the space shuttle is that it's sort of a contraption. If you've ever thought about it, there's various fuel tanks, there's engines, there's an actual lander, and which people sit in up here, and basically it's all kind of lashed together from different components. And that's one thing that's true of Obamacare as well, if not the entire US healthcare system. And the real question is, will it fly? Well, I mean, the space shuttle did have 2 or 3 major accidents during its period of operation, but for 20 years, it really, most of the time, it performed reliably. And so I think that the same question can be asked about how Obamacare will ultimately work out. So in terms of developing challenges, let me first talk about the political one. Well, we've seen that a number of things have been postponed. There have been congressional efforts to defund. I talked about that. Non-cooperation at the state level. Again, I mentioned that already. Other challenges, the ACA is complex. It's got 2,700 pages, plus 20,000 pages of regulations thus far. In other words, a piece of legislation doesn't actually govern the activity of public officials. What governs the activity of public officials is a series of specific regulations that are consistent with the intent and the content of the law. And the writing those regulations for a 2,700 page piece of legislation is going to take a very long time. The response to the individual mandate is uncertain. Now, this is an important point because in order to make the program solvent, there will have to be a lot of low-risk people signed up. So in the past, the people, remember from one of the slides I showed earlier, remember that young people who are at low risk tend not to sign up for health insurance if they can avoid it. If you can get it through your employer, all right, but otherwise they won't go out and look for it. Certain other ethnic groups in the United States, such as Latinos, have relatively low insurance rates. Again, for one reason or another, you could think of both of these groups as having rational reasons for not purchasing insurance. If you are, in fact, at low risk, insurance isn't as attractive. You use your money for something else. And, but in order to have the system be solvent, you need a lot of people who will not get sick who are in the plan. And there has been a tremendous push to attempt to enroll young, basically healthy people on the exchanges. Now, if that takes place, you have a chance at having solvency for the system. If the enrollment is a lot less than the hoped-for level, you will have problems. Now remember, I showed you some figures a few moments ago. Let's say if you had to pay $200 a month as a young single adult for health insurance, that would work out to be $2,400 a year. And if it turned out that you had to pay $500 or $600 a year as a tax, as a surtax because you didn't enroll in a plan, what would your choice be? So I think that that's a kind of thinking that's going on among a lot of people, and that's one of the major challenges that's going to come up. In terms of the actual cost projections of the ACA, I'd say that there's a certain amount of there's a great deal of uncertainty in those figures, and let me share some examples with you. So, for example, here is the projected impact of the Affordable Health Care Act according to the Congressional Budget Office, the agency that's supposed to come up with figures such as these, made just at the time the legislation passed in 2010. So basically, I'm giving you two sets of figures. One is 2010 to 2019. Total subsidies, that's subsidies on the exchanges and cost of additional coverage for Medicare, rather for Medicaid. It will represent a cost of close to $1 trillion. Now, where's that going to come from? Well, there's cost savings, remember, in terms of cutting payments to hospitals and some other facilities. There's tax revenues, taxation coming from the fees I mentioned on industry and the higher taxes for some people on Medicare plus for Medicare plus the taxes on people who do not subscribe. And if you take all these figures into consideration, it is argued that that for the period 2010 to 2019, we'll have a deficit reduction of $124 billion. Again, if you take the same figures and crank them through in the same way, make the same assumptions for the next period of time, 2020 to 2019, you will come up with a figure of a $681 billion saving of the U.S. deficit. Here's some controversial. Here's another way of looking at it. Now, what these folks did, an article in Health Affairs, interesting article, is they challenged the assumptions that were made by the CBO, and they added some costs that the CBO did not consider, And let me skip the details, and I'd be happy to go into them if people are interested later on. But for the period of 2010-2019, they come up with a figure of an additional deficit of close to $500 billion rather than a saving of a little over $100 billion. And again, at this point, you have to start reading the fine print and how people deal with net present values, various different conventions of accounting, and figure out how that all works. And that's beyond me, but I encourage you to read the article. And the site is down here at the bottom of the table. But let's just say that healthcare tends to be an uncertain kind of thing. I believe at the moment the CBO's projections have come up with reduced cost, which is interesting because there's been a slight reduction in the increases in medical care costs. However, we don't know what's going to happen in the future. New technology can increase costs, various other things that are unpredictable. But in any case, I'd have to say the projections have to be viewed as uncertain ones. Meanwhile, recent trends in private insurance are likely to continue, becoming more expensive with higher coinsurance and reduced benefits. Remember, this is not a comprehensive plan which exercises control in private insurance. I would like to close with a few thoughts. One of them, some quotations from people I respect who've done a lot of thinking about this. Oberlander and Marmer at Yale say the new law seems based on the hope that if a large variety of reforms are tested, at least some will succeed, but nobody knows how many will work in practice or whether they will save money at all. Another comment I thought was worth quoting from these same gentlemen. We do know that other rich countries that spend much less than the US on medical care do so largely by adopting budgetary targets for health expenditures and by tightly regulating what the governments and insurers pay hospitals, doctors, and other medical care providers. And Canada certainly fits in that category. The thought I'd like to end with to recapitulate the themes that I've used to integrate all this data and all these issues is to raise the question about whether by enacting Obamacare, the United States is heading into a kind of end of the beginning, under which the various initiatives and bits and pieces and experiments that are included in the legislation will result in an ability to care for a lot more people and still control costs, or perhaps the beginning of the end, which is having expanded coverage, increased costs will require more fundamental reform, and ultimately the United States will have to go to a system where the delivery mechanisms are actually changed and potentially cost controls are enacted. Thanks a lot for your attention. What issues or questions do you have? Yes?
Howard, I thought that was really interesting. Thank you very much. As you know, this health policy is an interest of mine. And I was really interested in the explanation behind, to the extent that you can shed some light on this, the explanation behind the change in popularity, the reduction in popularity or perceptions of how good of an idea this Affordable Care Act is over the past couple of years. I wonder, if that's because there have been some high-profile complaints and concerns raised about some specific aspects of what the ACA requires. Is it because people are starting to realize that they're going to have to pay for stuff they didn't think they were going to have to pay for? Do you have any information on what that sort of is related to?
Well, Erin, I think I can only guess. But I think the part of it has to do with political culture. And Americans are not particularly generous people. There's a feeling of meritocracy that if you have the income, you've deserved it somehow, and if you're having a rough time, you deserve to have a rough time. And then, of course, there's a lot of agitation by the Republicans. I don't want to vilify the Republicans, but it's good to have an opposition. I understand you don't have much of one here in Alberta, but it's good to have an opposition. It's just that the opposition seems to only have one thing that they can talk about, and that's health care. I really don't see a lot taking place elsewhere, and so if a good part of the electorate is responsive to the Republicans, which is a good thing. I mean, you want to have a competitive political system. That's what they seem to be arguing about. But there's probably a lot of other reasons having to do with political culture and a bit of a libertarian tradition that I think is behind this. I guess one other thing about the individual mandate, having thought about it, people, especially young people, if my kids are any or any example, don't like to be told what to do. And so I think that there's kind of a backlash among young folks. First of all, don't have a lot of money. I mean, $2,000 a year, $2,400 a year is a lot of money. And they would rather spend it on something else, and perhaps their decisions in that regard are rational ones. Other thoughts or issues? Yes.
So you were saying how previously insured people now have to pay more money. Is it just the increase in cost? Is it just for like administrative purposes? Like, is there a reason why they increase the prices?
Well, I would say, first of all, that's a very small percentage of the population. Remember, most people get their health care through employers, which are large group plans, or through Medicare or Medicaid, which are big government plans. And maybe a small percentage, I would guess 1 or 2%, no, maybe it's a little higher, maybe about 5% of insured people have individual coverage. In other words, they go out to the marketplace and they buy plans just for themselves. Now, for those people, in the past, they were able to buy stripped-down plans with very few benefits, which makes sense for a lot of people. If you're young and healthy and you don't have a lot of discretionary income, it makes sense to buy a plan which covers something which will require a lot of money and which is quite unlikely. And insurance companies sold those to people. Now, some of those people wanted to continue those plans but weren't able to because of the mandate that insurance companies need to offer a wider range of coverage. So we're talking about perhaps 5% of the population that has individual coverage, and among those a small minority that found that they were faced with buying a plan that cost more money. So it's a small number of people, but it's very politically salient. Other questions? Yes, sir.
There's a number of articles and sort of infographics out there about the cost of comparable services between countries and how the States pays a higher amount for, say, CT scans than other countries. Does the ACA address what hospitals are allowed to charge for services at all?
Well, I would have to plead a little bit of ignorance on that. But let's just say I think you have a really crucial issue. And this is one thing I really wish I knew a lot more about. That's one reason I'm here, because I'd like to get a sense about why costs of individual units of service are lower in probably every other country than the United States. It's a very, very good question. In terms of what hospitals get paid, most of what hospitals get paid are still through the private insurance system, and that's negotiated individually between hospitals and other entities and individual insurance companies. So I'd say the big picture is that it's all open to negotiation, and there is no regulation around that. In terms of Medicare and Medicaid, it's different. There are mechanisms for prospective payment, that is for a particular type of admission. The hospital will get paid a preset amount of money, whatever they do while the individual is in the hospital. Some other mechanisms which operate similarly. But I would say the big picture is individual negotiation between a private provider and a private insurer. Yes?
What are there any repercussions when a state opts out the Medicaid part?
None. The Supreme Court, the law of the land, said you can impose a tax. You can charge people as individuals for not enrolling, but the Supreme Court said you cannot mandate individual states to increase their coverage, the eligibility range for Medicaid, and so states do not have to do that, and many of them will not. Local democracy in action. Yes.
So the states that opt out of expanding Medicaid and offering the exchanges still have to impose the individual mandate?
Well, Megan, the states don't impose the individual mandate. That's federal law. And you pay the tax on your federal income tax. And they're probably printing the forms as we speak. So next year, if you didn't have insurance when your federal income tax is due, you have to check the box which says I do or I do not have coverage. And if you don't check the box, there'll be a little instruction telling you how much you have to pay for not having it. The mechanism is federal income tax. And I have to say, there has to be a verification plan around this, and this could work out to be another delay. because there's umpteen hundred different insurance companies in the United States, and insurance carriers and agents. It's a huge industry. And right now, there's a lot of concern about when 2014 income taxes come due, whether there will in fact be a mechanism for the federal government to check on whether the individuals filing the return actually have the insurance. So again, thinking about that guy struggling on the treadmill, that's just another couple of steps we'll have to be concerned with. But it's basically, that's a federal issue, not a state issue. Anything else? Other questions? Yes?
Can you speak at all to how they picked the levels for the penalties for non-enrollment? Like, there's such a huge discrepancy that it seems incredible between what it would cost to be insured and what it costs to simply pay the penalty.
I don't know. It's a great question. I mean, you know, if you think of a human choice matrix, you know, would you rather pay $95 a year? Let's say you don't think you need insurance, would you rather pay $95 a year to avoid getting insurance, or would you rather pay $2,400 a year to get a cheap policy? You know, it's a very good question. Now, I asked my friends in the economics department about this. You know, what do you expect to happen? You know, we realized that in order to make this fly, we need to have a lot of young, healthy people who traditionally do not buy insurance if they can avoid it. What's the likelihood? And they say, well, we can't predict human behavior. So, well, they can't predict human behavior, but I think your question is an extremely legitimate one. It's you wonder how those figures were arrived at, and I do not have an answer. Other questions, issues? Yes?
Howard, I know you might be reluctant to speculate, but if you had to put some of your own money on the line, in 10 or 20 years, would you predict that some of the cost issues and other issues that you've identified are going to push the system more towards public investment or public provision for regulation of health assumes a greater and greater role, as in Canada or to a lesser extent Western Europe, or you think that the U.S. is going to retain this commitment to having greater level of individual choice and a diversity in the way that healthcare is delivered?
So I've got to bet money on that?
That's right.
How much?
That's a good question.
Well, you know, I wish, again, if I had to bet money right now, if for a reasonable amount, for a couple $100, I think I bet that the system is going to remain as it is, essentially. Just because, you know, political culture is very powerful. You know, the Americans don't like big changes. Okay, give me a time frame. How about 20 years? If the system,
I said 10 to 20. So why don't we put
let's say 20. Let's make it 15. If you make it 15, I'll take
I'm going to make it $1,000 of your own money too.
$1,000.
Raise the stakes a little.
$1,000 U.S. or Canadian? Okay, $1,000. How about this? In 10 years, it will not change significantly for 1,000. Even odds, U.S. Okay, got it. I will take that. And the reason why is because the culture is very powerful. Political culture is very powerful. You know, for all we know, we could have a Republican in the White House in 2017, and that would make a big difference. The U.S. Senate, the Democrats do not have any hope of capturing the House of Representatives in the upcoming election, and the Republicans could well capture the Senate. So an awful lot can change, and if that changed, you're going to see a much more conservative approach to health care. The other thing I have to say, again, thinking about the other side, you know, to give you some hope of winning the bet, that one thing that happened, one of my favorite anecdotes, is that back in 1965, when Medicare, which is our system for taking care of elderly people, and Medicaid, system for taking care of poor people, was enacted, Lyndon Johnson, who was president at that time and pushed the legislation through, very, very effective president in that respect, was confronted with the fact, based upon actuarial and epidemiological considerations, that within 40 years, the program that cost $6 billion in its first year of operation, 1966, and 40 years later, which is about now, that the program would grow from $6 billion to something like $400 billion, which is about what it costs. And he said, well, Mr. President, you realize this is the future. This is what's going to happen if we pass this legislation. And he said, don't worry about it, do it anyway. And, well, you know, he's been dead for 30 years. And I have to say that there's certain mentality around that, because I'm not an economist, I'm not an accountant, but I think this is going to be a lot more expensive than the CBO's figures indicate. And if that really does happen, then you win the bet. We'll have to do something about it. Thanks, everybody. Great talking with you today.
And just as a very small token of our appreciation for your visit and your talk here today, I'd like to give you a copy of a Health Law Institute edited book, edited by our own, co-edited by our own Timothy Caulfield, Healthcare Reform in Canada, published in 2002, courtesy of the University of Alberta Press. So,
thank you so much.
There you go.
Appreciate it. Guess one other thing.